So delegates are slowly filling the hall, but we need to start on time. So I would be welcoming you on behalf of the organizing committee at AIMS Patna for the 11th Aroi-Estrp Advanced Technologies teaching course. And we truly welcome you to this Asian city of Patliputra. It has immense historical importance and a lot of other things as well, like Lord Buddha attained his enlightenment over here. And likewise, I think this teaching course will enlighten a lot of us. So we have as the Master of Ceremony, my colleagues from the Department of Radiation Oncology, Om Vinashri and Alokit, and they will be taking over. Thank you so much.
A very good morning to one and all gathered here. On behalf of Department of Radiation Oncology, AIMS Patna, I welcome all of you to the 11th Aroi-Estrp teaching course on Advanced Technologies in Radiation Oncology. Theme, Closing the Gap with Advancing Technology.
A very warm welcome to all the distinguished faculty, speakers, and delegates attending this teaching course. We welcome distinguished international and national faculty and radiation oncologists from different parts of the world for this course. I am sure that at the end of the course, the participant will immensely benefit from the technologies and deliberations of the course. Our first session will be taken by Dr. Ben Hasman and Dr. Indranil Malik. Please welcome Dr. Ben Hasman and Malik on the stage for introducing the course.
Dr. Ben Jem Hedgeman is medical physicist and professor of radiation oncology physics at Erasmus MC Cancer Institute. He has authored over 270 scientific publications and has received numerous accolades, including the Astro Lifetime Achievement Award. Dr. Indranil Malik, consultant radiation oncologist, is MBBS and MT Radiotherapy, Tata Medical Center, Kolkata. Dr. Malik has also received the Kataria Memorial Gold Medal as the best postgraduate student among all specialties and PG IMER from Princess Margaret Hospital. Welcome, sir.
Good morning, everyone. Can everybody hear us? So a warm welcome to Patna for the 11th Aroi-Estrp Advanced Teaching course. This course has been, the oldest Aroi-Estrp course running in the country. It has been, supported by students from India, from other surrounding countries, and it's been one of the more popular courses in this platform. I would like to thank Professor Manoj Gupta for coming to this course and Dr. Pritanjali Singh, who has been the local organizer for this course. Now, when we talk about advanced technologies, radiation oncology is supported by a lot of new and emerging technologies. Now, for many of us, we have not had the opportunity to specifically train in many of these technologies. And sometimes when we, change jobs or we, get new technology in our departments, we are not always sure how to use them to the best of their abilities. And we also sometimes find it difficult to critically examine technology when we want to make a plan for purchasing new technologies. So what we want this course to be is to be an interactive discussion on a number of topics that we felt would be of practical importance. We also want this course to be as multidisciplinary as possible because I'm sure all of you understand that advanced technology rests on not just on doctors, but on the physicists and the radiographers or RTTs that who are the real end users of technology. And therefore, our goal shall be to, examine these technologies together. The other thing that is very critical is that, when we look at technology, we should not be looking at technology just as aficionados. We should critically examine these technologies, see what they're good for, look at the impact they've had on the patients that we want to treat. So this course aims to do all of that. We have laid out for you, a comprehensive teaching program covering many of the advanced technologies that are here. We've tried to make this course, cater to not just doctors, but to trainees, to physicists, to radiographers. We will be using some new interactive tools during the course, like online polling. I'm going to talk to you about it after Ben introduces the course to you on his behalf. And we want you to come and meet us during the breaks and clear any doubts that we can't clear over here. Over to Ben.
Good morning, everybody. I would like to welcome you on behalf of Estro. So we are in four here from Estro. So there is Mairead Dali, there is Mika Palmu, there is Andrew Hope, and it's myself, Ben Hyman. By the way, our president, Matthias Guckenbergen, greets you all. So he's happy that Estro can participate in this course, and so it's a great honor for Estro to be here. I would also like to take the opportunity to thank also several people from your country, from India, for organizing and working on this course. There has been a lot of work, and so I want to mention some people. So there is, of course, you have seen the brochure, so there is patterns, and there is a chief pattern, and that is Professor Gopal Krishna Pal. So thank you very much. Then there is the president of Aroi, Dr. Manoj Gupta. And then the chair of Aroi, Dr. Rajesh Vashista. I'm sorry if I pronounced it wrongly. And I also would like to say a big thank you to Dr. Pritanjali Singh. Dr. Pritanjali Singh is the course organizer, and she has really done a lot of work to realize this course. There's a lot of things to think of if you want to organize such a course. Then there is Dr. Rajiv Parat Prasad. He's president of Aroi, the Bihar chapter. And last and certainly not least, I also want to thank my co-director, Indranil Malik. We are both directors, but I must admit that so he did most of the work. So I have the excuse that I was far. I don't know how good the excuse is, but so he did really most of this work. And yeah, so really I think Indranil and myself, we are very much on the same page if we talk about new technology. So what I will say here is a bit a repeat. Yeah, so there is at least three things. So there is interactivity. Yeah, so it really needs discussion. It's not that the faculty knows and you don't know, or it is. I mean, we have to share views, and there are different solutions to different problems, and so it's really important that we hear also from you what you do at home, what you think is right, and it's not that black and white normally. Also, if you look at the brochure, there is something that is in there that I mean, there is many things in there I like, but what I like particularly, and that says that we have to explore how to use the new technologies with a focus on scientific evidence, and I think this is crucial. I think certainly for the very new approaches like MR-Linac, ethos, protons, maybe even carbon ions, we should not only look at the nice images or the nice dosimetric studies. They really have to contribute to the patient care and the outcome of treatments and also toxicity. And of the, let's say, the more regular advanced technologies, so SBRT, IMRT, VMAT, this kind of technology, we have to really understand how to do it well, because it's very easy to also with these technologies that you think that you improve something for the patient, but if you do it wrongly, it may even be harmful, or you don't get any added effect. So it's really important that we also understand very well these technologies. So so lastly, I would like to very much welcome Marit Dali and Prakash. I have to look at his name again, Umbarkar. It's very nice that they are in this course. So for many years we didn't have RTTs in this course, and certainly it's Estro's view that radiotherapy is really a interdisciplinary endeavor. We have to really work as a group, so it's very important that you are here, and also that that RTTs but also physicists. So we already had physicists, but we still have physicists on board in this course. So thank you very much. I wish you a fruitful course and a nice period here. Thank you.
So I completely disagree with Ben. He put in hours of effort, that number of hours we spent discussing and thrashing out the program online. It was really a privilege working with Ben as the co-director. Now, what I came back to talk to you about are two things. The first is that we've set out 4 or 5 clinical sessions where we want to engage with you and take you through processes step by step. One of those has planning homework, which many of you have submitted. The physicists, several of you, the teams have submitted. There's also contouring homework for the lung SBRT case. And there are 2 cases where we would like you to contour by tonight, as many of you as possible, so that we can discuss them in detail tomorrow. The second thing is I wanted to ask you a few questions. And what we are going to do is we are going to cover some topics on with online polling. We want to know who you are, what your practices are, how our teaching helps you modify those practices, if at all. So what we're going to do is before we start, we are going to we want you to use your mobile phones. This is an app called Mentimeter, and we want you to go to this website called menti.com and type in this code. Right? We would also request as many of you possible to come in front, because we want to see you, and we can't see you if you're right at the back. So if we could all move in front and open this site. Are any of you facing any problems reaching the site? Please, let us know. And once you've gotten there, we want you to answer the first question. We just want to get the hang of how many of you are radiation oncologists, how many of you are physicists, how many are therapists, and so that we can cater our discussions, our approach to suit you best. Okay, we would like all of you. I can see there are like 30 odd people, so I'm waiting for about 30, 40 answers over here. So as we can see that we are basically radiation oncologists with, some physicists and radiographers. If you're done, we'll move on to the next question. Anybody still doing it? Right. We want to know how experienced you are. Are you still training? Have you been practicing radiation oncology for a long time? Right, so we seem to have a mixture of relatively people who are relatively new in this field to people who are quite experienced, more than 10 years of experience. We've also got a few trainees, and we're very happy to have you over here. And we want to know your exposure to a number of, technologies that we are going to discuss. So please click as many as you have exposure to. Okay, so it's not just one answer, you can click many answers. So what's coming out is really interesting. It seems that there is quite a wide exposure to many of the technologies that we are going to discuss in the course. It's also quite interesting that several of you have exposure to AI-based contouring and planning as well, and some of you have exposure to proton or ion therapy. So that's very nice. So we now know you a lot better, and we are happy to move forward with the course. So, and final question, why are you here? Why do you want to know about advanced technologies? So we want you to rank these choices. What is the most important reason that you're here? And we want to see what it is that's driving you to attend this course. So pull up your choices, put them in the right order that you want to. Yeah, so that's really cool. So we are here for different reasons. Some of us and most of us are here to help learn new technology to have an impact on patient care. That's great. Thank you. Thank you. So we'll move on to the next the talk to Dr. Hope's talk.
Thank you, Dr. Hasman and Dr. Malik, for the insightful introduction.
We'll now move on to our next session, Clinical Rationale for Using Advanced Technologies. To shed light on this crucial topic, we are honored to have Dr. Andrew Hope, an expert in the field, with us today. Please join me in welcoming Dr. Andrew Hope.
Dr. Andrew Hope is Associate Professor in the Department of Radiation Oncology, University of Toronto, Princess Margaret Cancer Center, University, Health Network, Toronto, Ontario, Canada. Welcome.
Over to you, sir.
Thank you very much for the invitation. While they're getting my slides up here, just want to make sure we have the right. I think you may have named the Dr. Daly talk. There we go, that's perfect. Excellent. Okay. So I think as Indranil and Ben were saying, really the purpose of this course, I would say, has largely evolved over many years to try to get people interested and engaged while understanding the basic concepts of our approach with advanced technology. And so I do have some disclosures, none of which are actually relevant to this general talk. But I think this is probably the most interesting slide for me because this is one of my favorite authors. And this is a quote from Arthur C. Clarke that basically says, any sufficiently advanced technology is indistinguishable from magic. And I think it's an important thing to think about because many times when people are considering technology, they think of it as kind of a magical thing that happens. And really, until you understand it, it can seem almost like it happens without any sort of understanding or input. And I think the example that I remember from my training was when we first started seeing IMRT become pervasive, we would see targets like this, and we'd be like, oh, we can't treat this patient. They've had 2 or 3 courses of radiotherapy to this spinal level before. But in fact, when you add a little bit of magic, you can actually warp a dose around that. And at the time, when I was in training, this was really magical. This is something that we couldn't have done previously, and the presence of IMRT allowed us to do things that we couldn't do before. We could wrap that dose around the cord and retreat patients that we couldn't previously. And so just like most of you are interested in, this allowed us to do things and help our patients in ways that we couldn't without this technology. But I think it's important to always ask the same questions Indranil was asking, which are things like, what is the clinical rationale, what evidence exists, what additional evidence may be necessary, and do the benefits of these technologies outweigh the costs? And how do we move forward once we've considered what's out there? So going through the clinical rationale, as was mentioned, I think the big 2 features that we're working on now are controlling tumors and ideally avoiding harm to patients. Most of us would put this in the opposite order, which is we want to do no harm and ideally control tumors. But both of these endpoints have been codified into something we consider kind of probabilities of outcomes. So normal tissue complication probability or tumor control probability are both relevant concepts when we're thinking about these sorts of endpoints. And the reason I bring these up is because these are the endpoints that we should be really examining when we're examining the role or the impact of an advanced technology on our patients. Because really, there are very few strategies to enhance the efficacy of radiation therapy. We could increase the differential response between tumor and normal tissue to favor normal tissue, so we protect the normal tissue. We could use superior dose distributions and reduce the radiation dose to non-target tissues, or we can develop methodologies to predict which radiation patients are benefited or have the biggest differential between tumor and normal tissue response. The problem is that most of these are really hard. The first one and the last one largely require us to understand the biology or the details of the patient and have maybe a drug or something. But the middle one is one that we can do with advanced technology, which is adjusting the quality or the character of the dose that we deliver and reduce that radiation dose to things we don't want to hit intentionally. And that brings us to the idea of what a superior dose distribution is. A superior dose distribution really just means that the treatment volume is reduced toward the target volume, but still covers it. And this has very significant relevance going forward because the definitions of what constitutes a target can change with the addition of advanced technology, and I'll touch on that later. But there's an important thing. The dimensions here include time, and I'll have a talk a couple hours from now talking about some of the roles of things like respiratory motion or motion or deformation that occur for patients while we're going through treatment, and these are things we have to think about now with our advanced technologies. But I think the rationale here is that when we have the maximum tolerance for a plan, it's really when we reduce that treatment volume to exactly the target, which is obviously technically, theoretically ideal, but not possible in almost all circumstances. But then the maximum dose should be the tolerance doses of the tissues that are exposed. And so this is the basis for things like SBRT, where we've conformed the dose distribution so tightly that we're now able to dose escalate very safely without a lot of acute or in some cases very much late toxicity. But this was not a new concept. This is back in, what, 1988? This is almost before, I would imagine, some of you were born. And so these concepts have been around a long time, and only now are we able to actually manifest some of these concepts with advanced technology. So things like dose sculpting, I mentioned IMRT, we used to be kind of blocky in the way we treated, and now I think everyone considers IMRT to be the standard of care. But in fact, for many years that was not the case. But it's important to remember that a lot of the knowledge that we gained over the last decades was gained when these dose distributions were not so conformal. And that has implications for our organs at risk tolerance, as well as our understanding of previous dose distributions and the impact on patient outcomes. So this is a slide that I borrowed from Dr. Rash from last year, where he talks about the idea of the GTV with these little microscopic areas around them, and that encompasses the CTV, and then the PTV. These are ICRU concepts that we're all familiar with. And within that, there's also a setup margin that we have to deal with that encompasses the PTV in some ways, that internal margin, and that's the treated volume that we mentioned. This is a standard slide, but the reason I bring this in is because the advanced technology that we're going to be talking about affects all of these concepts in some level. And that's where we're going to be increasing that therapeutic ratio, moving that ideally normal tissue curve farther away to the right compared to our normal tissue, compared to our local tumor control, the TCP curve. So, and this is where margins come into play, because this is a slide from Dick Verellen that basically talks about the idea that the volume that we have for margins increases as a cube of the radius around the target. And so you can see that when you peel an orange, the peel has as much volume as the orange itself. So those margins really do matter quite a lot in determining what happens. And so we'll have a margin talk just shortly. But I think in the end, the clinical rationale has to be that better dosimetry and better use of technology to conform the dose to the target and to avoid those things we don't want to hit should result in improved outcomes. But I think it's important to recognize there's a great difference between knowing and understanding. This is Charles Kettering, who you may recognize from the name of the Memorial Sloan Kettering. He's one of the original founders. He invented something that starts your car every day, the automatic car starter. He was an engineer and made a lot of money doing it and started funding the Kettering Institute as a result. But I think his engineering knowledge here made a lot of sense, because we can do things quite regularly, but we won't actually maybe know how they work until we dig down into them. And so let's dig down a little bit into some of the data. So here's an example. Do we really understand what a target is in most situations? How many people here would like to have the 4-field IMRT or the 3-field, or in this case 4-field 3D conformal? Who wants the 3D conformal treatment? Got one person back there from the 90s, excellent. Anyone here want the IMRT treatment? So almost everyone raises their hand. And of course, this is a trick question, because what I didn't tell you is that there's actually a microscopic target that we didn't know about. And so that microscopic target is a nodal volume that's, outside of what we would have contoured. Who now wants the IMRT plan? Right? This is an example of better imaging creating a problem, or better technology creating a problem that didn't previously exist. And so a lot of you are saying, oh, this will never happen. But there is an advantage in some cases to non-conformality, because there are things we don't understand about disease distribution that can be revealed when we change technologies. And so the monitoring of outcomes is actually quite crucial. And the example of this is the one that I really like, is this paper that came out in, I think, 2008. This was an exact situation where this happened. People took previously treated patients that had had nasopharyngeal carcinoma treated with opposite fields and started sparing parotids, and suddenly observed a small proportion of parotid failures because the nodes were microscopically involved. And in those patients, they experienced a local failure that would have never happened with a more traditional treatment because of the use of advanced technology. And if they hadn't been watching for this outcome, this would never have been recognized or would have not been known. But because people were implementing in a safe fashion and they were watching to see what happened to their patients, they were able to observe this change and learn something about the disease because of the way that they changed their treatment. We've done this before in other sites. So at WashU, where I trained many, many, many years ago now, we used to observe our IMRT head and neck failures, and we observed 2 different patterns, that we then incorporated into our treatment volumes, including the inclusion of high level 2, and again, a problem with the parotid line, and both of which we stopped using. We had match line failures and parotid failures, all of which were only detected because we used very careful outcomes monitoring. And we don't do those anymore, because it's been 20 years, so these are not as relevant. But these also apply to organs at risk. So this is an example of a patient that was treated with lung radiotherapy after mesothelioma surgery. And how many people here think that a mean lung dose for this patient is safe? 14 gray? 14 gray is usually ballpark range. Who would treat this patient with this plan? Who would not treat this patient with this plan? No one's treating this patient? That's very confusing. But I think this is interesting because I think 14 gray for most people would be considered normal. But in fact, when this was done clinically, half the patients died because this was IMRT delivered to a patient who had had a previous pneumonectomy. And those numbers don't make sense in that specific clinical context when you have large volume bath radiation of the remaining lung. And so I think this is an example of an advanced technology that went awry, not because we didn't use the technology properly, but because the clinical circumstances revealed to us some understanding of the organs at risk that we previously had not appreciated. Low dose to a remaining lung in a large volume can be dangerous. So what I think this shows us is that the incorporation of advanced technology should always be accompanied by monitoring of outcomes to ensure that we know what's happening, because we don't understand a lot of the dose volume constraints that we really use because they were derived objectively from old data. That old data that I talked to you about that was 2D, or in some cases 1D. These are old plans that we use to figure out what's safe and what's not safe, and they may or may not apply in this new advanced era. And I think that's why I wanted to just bring up, of course, Sherlock Holmes, or in this case, Sir Arthur Conan Doyle. It's a capital mistake to theorize before one has data. So what data do we have in these advanced technologies? So, for instance, I think the fundamental question is, do we need to have randomized trials for advanced technology? This is a great paper that you should totally read because it's hysterical, talking about a randomized trial of parachute use. And of course, obviously, no one enrolls on this trial where you randomize someone to jump out of a plane with or without a parachute, but many people have equated this sort of example to the example of advanced technology, because we know that in some cases advanced technology does things that are better, or we think are better. But I think it's in those two previous cases of both tumor control and normal tissue outcomes, I think illustrate the fact that we don't always understand what in fact is the safest way to approach. And so these sorts of things, I think, do deserve to be tested rigorously, and as Indranil mentioned, we should really understand what data exists. So I'm just going to touch on some of the data that we have for things like IMRT, advanced imaging, or adaptive radiation. In head and neck, we've shown that this improvement to IMRT has been associated with decreases in xerostomia in a randomized fashion in an NPC population. We've shown improvements in local control in nasopharynx, and that's why we think that IMRT is such an incredibly useful tool for this disease. Similarly, we've shown that IMRT improves both local acute side effects as well as late side effects in breast cancer. And so you can modulate the dose to give a better dosimetric plan and a better outcome for patients. And it's been shown again in a randomized fashion that this works. But what's interesting is that you can also show this in almost every disease site. If you look at specific endpoints and you craft your question well, prostate is better treated with IMRT in terms of both acute and late toxicities, and because it reduces dose to the critical structures. But we have to be aware of the fact that sometimes you can have improvements in dose because you can dose escalate, because you can decrease margins, and other factors that may be related to, but not specifically because of the advanced technology. But all of these have led to massively rapid IMRT adoption in the early 2000s, and as I mentioned, it's now standard of care for almost every site. What happens, though, when you add things like advanced imaging? So this is a trial that was performed in the Netherlands, and I believe actually around most of Europe. But the FLAME trial was basically a choice of using a dose escalation approach using an MRI-guided target within the prostate. This is, again, a very unique and important use of advanced technology because it combines combinations of upfront imaging, planning, target delineation, margin selection, and focal IMRT, all combined to create an improvement in overall survival. In this case, not overall survival per se, but it's prostate equivalent thereof, which is biochemical-free survival and disease-free survival, both of which have been shown to be improved by this approach. You can make an argument about whether or not this was the right control arm, because there's some question whether or not lower dose on the control arm may have been contributory, but I think the idea here is that advanced technology really does become a standard of care when you deliver it properly. And I think that brings us to the next step that we're all starting to work on, which is the change from standard radiation therapy that takes weeks to plan, and we deliver once a day for many weeks. And we know that this is, in fact, not what we're really delivering, because we're getting dosimetric variations, intrafraction motion, and deformations. So we now are thinking about online adaptive radiation therapy as the next step, but it's really just an integral progression of what we've had before. And the adapt daily approach, which is now on the CT-based and MR-based strategies, brings this down to the matter of 15 to 30 minutes, end to end, for a new plan for a patient on a given day. And this creates a new decision loop that makes lots of decisions required within a short period of time, but it hasn't been shown to improve survival or outcomes in some cases. This was an example of a randomized trial that compared online adaptive weekly to non-online adaptive and did not show an improvement in the endpoint that they were shooting for, which was improvement in parotid function, xerostomia. And I think this is important, because if you're going to invest tons and tons of resources in online adaptive, you really want to show conclusively that it actually improves the outcomes of relevance. And in this case, maybe they used the wrong endpoint, maybe they didn't replan as frequently as they should have, or some combination. But this is, again, evidence to suggest that there are some ways you can do online adaptive better than others. But I think the bottom line here is that all of these really address things like tumor control and normal tissue toxicity, and we really can test most of these in a clinical trial if we wish to, and I think we should. So what additional evidence is needed? Well, we can ask lots of questions, and I think all of you are actually in a position, especially here in India, to ask questions in high volume patient populations that we can't address in some parts of the world. So, can we ask simple questions like, what is the CTV coverage required? I know the Danish group, the Dahanka group, is running that trial right now about whether or not they can decrease their CTV margins. Can we decrease normal tissue tolerances in some context? How safely can we do that? Should we be adjusting our dose fractionations? Can we do that using the combination of margins and online adaptive? And what is the impact of heterogeneity on outcomes? All of these are things that we can think about, and there are many, many, many more questions that I haven't put on here that you can all think of that we should be thinking about when we're doing advanced technology implementation. But I think the benefits have to outweigh the costs, and this is what I think Indranil was getting to, is that we have to critically assess whether or not the implementation of these advanced technologies is really going to make a difference for our patients. I mentioned this Artex trial before, which is that weekly replanning. They did the actual analysis where they figured out how much money it cost to prevent one xerostomia case. Those numbers are not small. A couple €100,000 per patient to decrease the case of xerostomia. Is that really worth everyone's time and money to implement? We can all have a fight about this later in the course, I'm sure. But I think all of these have health policy issues. There's cost to the system, there's increased workload for staff, and there may be only incremental benefits. Some people might argue that the breast IMRT or combinations of breast immobilization, if we have a 15% increase in cosmesis, is that worth the cost of implementing IMRT across all patients that are going to be receiving breast cancer? What happens if we spent that on screening instead? Or we spent that on better chemotherapies or other strategies? There are lots of ways to slice this, and I think it's important to recognize that the pool that we're exploiting here to implement these technologies could also be applied in other ways within the health populations. But I think, how do we move forward? So don't use quotations, tell me what you know. Thank you, Mr. Emerson. What I know right now is that advanced technology are just tools. They may or may not be superior when they create a different dose distribution, and I think the clinical evidence to date supports the idea of superior dosimetry and superior outcomes, but I think it's worth testing. And I think that it underlies the issue that this is a function of dose, not technology. It's really how and where we clinically decide to put the dose that's going to determine your outcomes, not which technology you're using or how many technologies you're using. It's the end result of where the dose ends up. And our understanding of radiation response remains limited, and so we have to be cognizant of the fact that as we change things, we may perturb a system that we understood previously, but we may not understand going forward. And just be careful when you're doing things that aren't consistent with your previous practice. Don't make a sudden, 3-step leap and stop treating elective targets or change your margins enough that you might miss the primary target unintentionally because you're being too tricky with some new technology. And so I think we should be thinking about randomized trials, and again, places that have high volumes are the best suited to do this, and especially as things are being implemented, that is the moment when you can really have a trial. Before you have a trial, or before you have the technology, you can't do the trial, and after everyone's using the technology, you can't actually assess it safely because people won't randomize. So I think it's really important to take that opportunity when you're implementing to think about whether or not this is a question that you can ask or what question you should ask as you're rolling out that technology. But most importantly, monitor and report your outcomes, including patterns of failure, toxicity, and consider those databases that we all want to have for all of our outcomes so you can know what happens with your technology as you implement. I'd be happy to take any questions if we have time, or is it going to be afterwards? I don't know. So thank you.
Thank you very much. Very insightful presentation. I have a question on your question was a question. It was about cosmesis and breast cancer, 15% reduction. And is that a serious question, or?
No, I use that as an example for the cost effectiveness argument, because I think there are some people who definitely think that's important, every single patient that has breast cancer.
Yeah.
But I think from a health system standpoint, some people would make the argument that there are overall survival endpoints that may be more relevant from a cost effectiveness standpoint. But I think I raise that really as I would say a shocker question to try to get people to think about money versus technology versus endpoints.
Yeah, because I believe that this treatment is actually for that, right? I mean, to keep the breast.
100%.
And it should be in an acceptable status, I think, right?
100%. And I raise it because I want people to ask questions. I fully anticipate that half of my audience will usually raise their hand and be like, that's not okay. But I do that intentionally because I really do think it's a question that as a healthcare group we ask regularly. I think the fact that we all have IMRT now allows that question to be moot because it's a lot easier for most people to deliver IMRT properly than it is to not. But I think at the time there was definitely questions about whether or not IMRT for that indication was justifiable in certain jurisdictions.
So, just one question from
Sir.
myself. I'm Dr. Dinesh, I'm radiation oncologist. So, this Astro teaching course is ongoing in the resource constrained part of the country, this is Bihar, and do not have enough technology in all part of the state. So, do we have, at this point of time, do we have enough evidence or randomized control trial that we can say that IMRT is better than 3D CRT? Of course, 2D era has already gone, and we don't have enough machine. Now, in this part of the country, also we have IMRT and SRS, SRT technology. So, do we have enough evidence that we can say that the superiority of IMRT in the overall survival and other things?
Yeah, I think it's on a disease by disease and an indication by indication basis, but in a large number of situations, I think we do have evidence to support the use of IMRT for
yeah.
certain diseases. I think that's where I was trying to raise the question of, cost effectiveness.
Cost, yes. That's I just point. Evidence we have, but cost effectiveness, because you have pointed out the cost effectiveness.
Yeah,
Evidence
I think especially in resource-constrained environments where there's large volume of patients and limited numbers of either staffing or machines, there is still a question as to whether or not there's a fair trade going on if I have to not treat someone with one disease to make sure I give IMRT to another patient who has a disease, whether or not that's a fair trade in that limited resource environment. And I think that's something we should be talking about and thinking about.
Because my concern is we have enough number of patients, but patient load is too much. So in doing the IMRT, the planning and treatment, so we, with a large number of, I think, so the waiting time is so much. So patients deprived of the treatment, even 3D CRT, we can treat the all patient or more number of patients. So these things are very complex, I think.
I completely agree, and I think, as I mentioned, I think it does depend on your resource environment quite substantially. I mean, just because we have clinical evidence to show that the outcomes are different when you have a high resource environment may not apply when you can't treat 100% of the patients in a low resource environment. And I think that's that's why I raised that cost effectiveness part of this advanced technology discussion, is that because there are different constraints in different environments, and I think you've hit it on the head.
Thank you.
We'll take one last question.
Yeah, excellent presentation, but I would like to comment that there is much more than technology, the resource and all those things, that is disease biology. So if one patient, young patient, TNBC, probably having germline mutation for 30s, in her 30s, so shall we go for the IMRT, though we knowing that disease may recur? So on the basis of constraint of resources, if we do 3D CRT, but if the patient is having a good outcome in later part, so then we can say that if we would have been done IMRT. So this is another tricky thing. I would like to mention that disease biology is another thing, so we must individualize the use of technology, whom to give, whom to not, and our prediction is not always right. So that is
Totally
my
agree.
point.
And I think the example I like to use in this situation is that of SBRT for early stage lung cancer. I think that is a resource saving treatment that utilizes advanced technology in a very efficient way. You know, if you can do high quality SBRT, you reduce your treatment course from a very long course for lung cancer to just a few days, which means maybe you can, even with the increase in staffing and requirements to deliver the advanced technology, you still may be more effective overall at treating the same number of patients, because if you treat 20 patients with SBRT in the time it takes you to treat one patient for this longer course or two longer courses, maybe you end up in a better place in the end. So I think this is why it's a discussion, I think, is because there are these multifaceted variables and the constraints vary across the jurisdictions that they're employed in. So. Indranil?
No, thanks. We'll move on to the next.
Thanks.
So the next talk is by Dr. Tejpal Gupta. Can you put up the next question on mental health? Your practice on
Yeah, yes, Indranil.
yeah, we'd like to just put up a couple of questions on the online forum.
Okay. इसको minimize करो.
It's on Chrome.
Chrome पे.
Or did somebody close it off? Okay, never mind. I think we'll just go on in the interest of time. We can start with the talk. Thank you.
Okay. Good morning, everyone. I think those who are sitting at the back, maybe you can still come a bit forward. I'd like to thank Indranil and Ben for their hard work in creating the content for this course. What I have been given to talk this morning is on principles, opportunities, and challenges of incorporating modern multimodality imaging for target definition. I've added treatment planning to it. So, this doesn't move. We all are familiar with the radiotherapy process and workflow. It's a chain of processes. Starts from decision to treat with radiotherapy, and then you take a planning CT and do your definition of target volumes, organs at risk, do all the treatment planning, verification and delivery. Sorry. This doesn't move. So we all know that radiotherapy is an image-based or image-guided intervention, and the evolution of radiation therapy has been linked to medical imaging. Advances in medical imaging have led to sort of advances or evolution of radiation therapy for the last 30, 40 years. And developments in imaging have consistently led to paradigm shifts in target volume delineation, starting from based on clinical judgment and planar imaging in the 1960s, 70s, 80s, to now using molecular imaging for target volume delineation in 2010 and beyond. So all the developments in imaging have led to shifts in the way we delineate our targets and organs at risk. Now, these new technologies require precise localization and definition of target volumes and organs at risk. Like Andrew mentioned, IMRT VMAT is the contemporary standard of care. There is evidence across several sites now that it is better than the 2D/the 3D way of doing things. And evidence for that exists in the form of randomized controlled trials. Since the dose gradients are very sharp with IMRT VMAT, the delivery of radiation dose also has to be precise and accurate, and that's why you need the concept of IGRT or image guidance for delivery verification. So the higher precision and accuracy requirements in radiation planning and delivery has led to the need for image-based and image-guided radiation therapy. Now, as far as contouring and delineation is concerned, of course, it is dependent on the imaging modality that you choose. We all use CT as the primary data set, but increasingly now MR and even PET are being used to improve our imaging, the delineation of our target volumes. One needs to follow delineation protocols. Consistency is really required for ensuring good results. Not only the target, even OAR needs to be defined and delineated well and accurately. And we all know that variability, inter-observer variability in contouring and delineation is actually the weakest link in the chain of RT processes. So as you saw in the second slide, radiotherapy is a chain of processes, and contouring and delineation is actually one of the weakest link in this process. And some data to suggest that in head and neck cancers, actually the inter-observer variability in contouring and delineation is one of the highest that has been reported. So there is a clear need for improving the consistency and uniformity of contouring. Now, as I said, we all use planning CT as the primary data set for delineation. It's required for dose calculation. So I'll just skip some of these slides. I think most of you are aware and use this quite regularly. The advantage is that it provides good spatial accuracy. You have the electron density information which is required by the treatment planning system to compute the dose distribution. The disadvantage is that it has poor soft tissue resolution, and there can be image degradation secondary to artifacts. And this is an example of a dental artifact that causes degradation, and it's difficult to use that image for delineation properly. You can see on the left is an MR which is showing the lesion very clearly. Now MR, over the last 2 decades, MR has been increasingly used. The biggest advantage is that it provides excellent soft tissue resolution. It has multi-planar and multi parametric capabilities, and you can do functional and molecular imaging as well. Of course, it comes with its own disadvantages. There are motion artifacts, susceptibility artifacts, and geometric artifacts. It takes a much longer time and is relatively costlier, and it lacks tissue density information which is required for treatment planning and dose computation. Although now you can actually do a synthetic CT generation with the MR, some of which is commercially available. And it is rather difficult to use immobilization devices on a standalone MR. Of course, if you have an MR simulator at your disposal, you could use the immobilization devices while doing the MR simulation. MR is a multiparametric imaging. It combines several sort of techniques, including diffusion and perfusion and spectroscopic imaging that allows reliable diagnosis, particularly in certain situations such as brain tumors. And you could use a T1 weighted, T2 weighted, ADC, DWI, all kind of images can be used to guide your target volume delineation. This is a typical MRI protocol for CNS lesions. Of course, when you're using it for target volume delineation and MR planning, you have to make sure that you use appropriate images in the context of the disease site that you are treating. It gives very good visualization of soft tissues as opposed to CT scan, where it might be really difficult to identify. And particularly in brain tumors and several other sites, you really can't see much on the planning CT, so you have to have an MR to delineate, because if you can't see the lesion or the target well, then you can't draw it well, and if you can't draw it well, you can't treat it well. And same holds true for OAR. If you can't delineate your OAR well, you can't avoid the OAR well. The MR sequences, particularly in the context of brain tumors, for enhancing tumors, a 3D volumetric FSPGR sequence. For non-enhancing tumors, you have to use the T2 weighted and the FLAIR sequence. We routinely do all of these sequences in a volumetric manner for planning of primary brain tumors. This is a summary of the commonly available functional MR techniques, some of which can be used for contouring and delineation, particularly the MR spectroscopy for identifying the high-risk areas in glial tumors if you want to do a selective subvolume boosting. We'll come to that towards the end of the talk. Of course, motion artifacts are the bane of MR imaging. So in the head and neck, particularly the laryngopharynx, it might not be an easy thing to use unless you use a cine MRI mode. You will get a lot of artifacts, and that's not what you really want. Coming to PET, it provides functional and metabolic information. There is better differentiation from normal tissues when you combine it with integrated PET CT. It can identify small involved nodes that would have been considered uninvolved on just pure CT imaging. Disadvantage, inherently poor spatial resolution unless you combine it with a CT. You can have partial volume effects, you can have false positives, and it is more expensive. It was limited, it had limited availability a few years ago, but now increasingly it is becoming available in clinical practice in the vast majority of centers. Now you have to remember that there can be physiological FDG uptake, which can be sometimes misleading and confusing. Generally, that would be largely symmetrical and bilateral, so you can actually sort of differentiate physiological versus pathological uptake. This is, if you do a PET CT simulation, these are the technical requirements for PET CT simulation. You need a flat tabletop, a laser bridge, the Hounsfield unit calibration curve imported into your TPS, and a regular PET CT QA for radiotherapy. Also, you require the patient to be set up in the RT position. You have to select the tracer that you want to use. So for brain tumors, FDG PET is not the best tracer. You have to use an amino acid tracer, but for other sites like lung and head and neck, FDG PET is to be used. The QA of PET-based RT dose painting has also to be done if you want to do a dose painting approach. Some of the caveats in using PET for RT planning, signal uncertainties and signal distortions, and this has to be taken into account when you do use PET for radiation planning. These are some of the radionuclide imaging techniques and tracers that you can use. Most commonly used is FDG as far as lung and head and neck is concerned, and amino acid PET as far as gliomas are concerned. Now coming to multimodality imaging, what do you mean by multimodality imaging? It's the combination of different imaging modalities such as a CT, SPECT, MR, or PET to integrate different kinds of information, and that information can be morphologic, it could be pathologic, biologic, physiologic, or metabolic. So technically it is defined as the integration of two or more imaging modalities in a single examination to provide accurate spatial localization and quantitation of function, ideally done via incorporation of multiple imaging modalities within a single or a hybrid scanner such as a SPECT CT or a PET CT or a PET MR. Alternatively, you can acquire two sets of images separately in a CT and MR PET and fuse them using registration algorithms. So a CT and an MR or a PET with an MR acquired separately. Now, application of this multimodality imaging as far as radiation planning is concerned can be for simulation, target volume delineation, escalation of dose or selective subvolume boosting, and even response adaptive radiotherapy. It's very important to ensure that you have a quality assurance program of the image registration and fusion. So the AAPM task group 132 report actually describes this, and it's very important that you and your physicist are aware of this and make sure that the registration and fusion algorithm is clinically integrated with a QA program. Now, sometimes we come across terms that we use very interchangeably and it can be confusing, registration, fusion, transformation, segmentation. So registration is sort of defined as geometric alignment of images. Fusion can be considered as mapping of information on each image. Transformation is a function applied to align those images, and segmentation is delineation of images to a named anatomy. So this is how the official technical definitions of each of these terms is. It could be your multimodality imaging registration could be same modality, so it could be CT with CT, it could be same patient, it could be different modalities and same patient, it could be same modalities and different patients. So there are several ways in which you can actually co-register sets of images. This is the broad framework for image registration. So you have a fixed image and a moving image, and you use a registration metric, use a transformation algorithm. The optimizer works on that, and then you get a fused image. This is a process that is done repeated iteratively until you get the most sort of acceptable similarity measure. There are several models for doing such transformation. The most commonly ones are that use the rigid or the global linear transformation. You also have non-rigid or deformable registration, which is becoming more popular and more commonly available commercially. And then you have the general linear transformations as well. Now, this is just a snapshot of commonly used transformation models. How they sort of do it and what is the maximum dimensionality of the transformation. Increasingly, people are now using deformation models, actually deformable registration. So this is the workflow for deformable image registration. As a radiation oncologist, you need to understand that everything is not sort of static, and that's why when you use a rigid registration, there is a loss of sort of data, and a deformable image registration allows you to map more accurately or propagate the dose or contours more accurately as opposed to a rigid registration. Now, what is a registration metric? It is a measure of similarity or dissimilarity. It can be either geometry based or Euclidean criteria based, such as distance, surface, or volume. Most commonly now, a Euclidean criteria based registration metric is used, although originally mostly a geometry based registration metric was defined. It could be voxel intensity based or it could be feature based, and mutual information exchange algorithm is one of the most commonly used algorithm present in most commercial registration and fusion algorithms. Again, the AAPM task group 132 report describes all of this in quite a bit of detail. So as I said, the mutual information exchange algorithm, that's the most commonly used, and it sort of provides a high sort of degree of co-registration accuracy of the order of 1 millimeter or less. What are the metrics that you can use to evaluate your image registration? Again, there are several of them. The target registration error, mean distance to agreement, dice similarity coefficient, the Jacobian determinant, and all of this or any one of this can be used to sort of evaluate how well your image has co-registered. You should always manually check for the accuracy of the auto fusion or the auto registration. There are different commercial vendors have different sort of features for this. This is the spyglass from BrainLab, but I mean similar things you have in other commercial registration algorithms as well. How do you co-register your PET with your planning CT? Again, there are several methods to do it. You could use rigid registration, which is the most commonly used, but also deformable registration. Ideally, if you use the PET CT, integrated PET CT simulation with the mask and the patient in the treatment position, you don't have to co-register, but most of the time we do it separately, so you have to co-register. Several methods have been described. One is not better than the other. There is visual method, absolute thresholding, fixed relative thresholding, the region growing technique, the gradient finding technique, and adaptive thresholding. For brain tumors, particularly high-grade gliomas, the T1 post-contrast MRI, which is the GTV MRI, is the reference standard. For different other anatomic sites, you could have a different sort of reference standard. So, this is an example of FET-PET guided delineation of GTV in a glioblastoma. So you can see GTV MRI, which is the reference standard, and then you have GTV manual, GTV region growing, and GTV signal to background ratio adaptive thresholding. And if you look at which is the best method, so this is a comparison of various PET segmentation techniques for newly diagnosed glioblastoma using FET-PET imaging. And adaptive thresholding using the signal to background ratio 1.6 was suggested as the most optimum method with biopsy-based correlation as far as GBM is concerned. In head and neck, typically most of the time you use SUV max 40%. In several other sites also that is commonly used. But different sites will have a different sort of PET segmentation technique would be optimal. It would be different technique would be optimal for head and neck or pelvis or lung for that matter. One thing that we know from PET-based delineation, particularly the amino acid PET-based for gliomas, is that there is a poor reproducibility of it. So this is an example from the FIG study, which is an ongoing study in Australia, where they looked at inter-observer variability or reproducibility, and they found that the FET-PET based delineation was much more variable than the MR based delineation. Of course, there are spatial differences between MRI and amino acid PET, and that has implications for target volume delineation and radiation planning. So you can see this is a contrast, T1 contrast enhanced MRI, that's the flare image, and the FET-PET to the extreme right. And these are, if you look at volumes, they are very different between FET-PET and contrast enhanced MRI. And typically the FET-PET based volumes are larger than the MRI volumes. MRI is currently considered the gold standard for target delineation in CNS tumors, and we typically use MRI, but amino acid PET can provide complementary information. You could also use multiparametric MRI and FET-PET to identify hotspots or aggressive areas within the tumor. This is an example which uses identifies these aggressive areas for selective subvolume boosting, and they may be amenable to selective dose escalation using these multimodality imaging. Volumetric changes happen during a course of fractionated RT, not only in glioblastoma, for that matter, in most sites, and that provides us a potential and opportunity to do adaptive radiotherapy. This is an example from the glioblastoma or the CNS domain. As you can see, over time there has been change in the target volume, and that you can make out much better when you use a planning MR throughout the course of radiotherapy. Does this change in volume or adaptive radiotherapy impact upon outcomes? The answer is not very clear. This is again an example from the CNS world. This does show that change in volume actually impacted upon outcomes, but that data is not so consistent as far as other sites are concerned. Andrew showed the Arctic's randomized trial in head and neck. Weekly adaptive CT did not change or improve outcomes as far as head and neck cancers was concerned. This is just a summary of the advanced imaging techniques for radiation planning in adult diffuse glioma using both MR and PET. As I said, both these technologies are actually complementary and not competitive. You could use dose painting for treatment planning, and advanced imaging modalities allow you for better use of dose painting. So as we know, the more resistant areas of the tumor, you could actually do selective subvolume boosting. Generally two approaches for dose painting. One is dose painting by contours, the other is dose painting by numbers, which is a voxel level prescription of dose based on a mathematical transformation of the image intensity of individual pixels. Can be applied to CNS, can be applied to head and neck, can be applied to cervix, any anatomic site or disease. You could actually use dose painting approach for selective subvolume boosting. One of the examples from the CNS world, the SPECTROGLIO trial, where they used dose painting in GBM. This was a randomized control trial where the choline, based on MRSI, MR spectroscopic imaging, choline Na ratio more than 2 was selectively boosted to 72 gray. Unfortunately, the trial did not show any improvement in survival despite the selective subvolume boosting. At our institution at Tata Memorial, we are using a randomized trial where we are using PET guided sequential boost and not a simultaneous integrated boost in unmethylated glioblastoma. The trial is currently ongoing. We've randomized close to 140 patients on the study so far. Coming to the last bit, which is radiomics for segmentation and delineation. Radiomics and radiogenomics is the buzzword. Radiomics refers to automated extraction and analysis of large amounts of advanced quantitative imaging features with high throughput from medical images that can then be used for automated segmentation and treatment planning as well as predictive modeling. Now most of the world uses machine learning approaches and deep learning approaches for segmentation, and some of the vendors are now providing this commercially as well. There is a rapidly growing popularity of deep learning approaches for medical image processing. So if you see the number of publications in deep learning has significantly increased over the last 5 to 10 years. And again, just like you had metrics to assess co-registration, you have metrics to assess auto-segmentation performances, volume-based metrics, distant-based metrics, dosimetric metrics, efficiency metrics. So you can actually assess how your auto-segmentation algorithm is working. These are some of the studies that have used machine learning, deep learning approaches for segmentation for radiation therapy planning. This is an example from the CNS and head neck domain. Similar examples exist for pelvis and other sites as well. Finally, based on all of this, can we deliver a personalized radiotherapy prescription? Will it be a reality in the near future, or would it remain a utopian concept? I really don't have a good answer. I think it's more utopian than real. Although we are moving in that direction, I think we are still very far away from personalized radiotherapy prescription. So to conclude, multiparametric and multimodality imaging are here to stay. one should be aware of the benefits and pitfalls of each of the imaging technologies. PET, CT and MRI are complementary and not competing modalities. I would say all imaging modalities have their own sets of advantages and disadvantages, and they don't necessarily compete with each other. PET CT scans provide useful adjunctive biological information, both in the CNS and head and neck and other sites as well. Integrated PET MR scanners represent a big technological advance. AI ML algorithms can substantially reduce time for segmentation and improve inter-observer variability for target and OAR definition. However, clinical acumen and human analytic capability should never be ignored. Thank you for your time, and I'm happy to take questions. So, one is that your diagnostic MR scan is not a 3D volumetric scan unless you acquire it in, you have to set the acquisition parameters. So, typically it is a 4 millimeter, 5 millimeter, 6 millimeter slice thickness. There's a lot of loss of information if you do that. And if you sort of reconstruct it in another plane, there will be further loss of information. So, if you want to use MR for planning and co-register it with your planning CT, it is best to acquire a specific planning sequence rather than use the diagnostic sequence. I don't think it's a great idea to use. Of course, it is better than doing it on the CT, because for the brain particularly, you would not identify too many things on the CT. If you're suppose treating a diffuse glioma, you would need an MR. I would strongly recommend acquiring a planning sequence with the diagnostic imaging itself, which is a 3D volumetric sequence, because that allows, I mean, the diagnostic sequence will have loss of information.
Hello sir, very nice talk. Sir, how much dose you prefer in sub-volume boost in post-op GBM cases?
Please don't, I'm not trying to say that you should start doing selective sub-volume boosting. We are doing it in the context of a randomized trial. Currently, the current recommended standard of care is to do the 60 gray in 30 fractions to whatever is your defined target volume, either using the EORTC single phase approach or the RTOG two-phase approach, 46 and 14. So I don't want to send this message across that from tomorrow you should start using selective sub-volume boosting. If you have any such thought in mind, please do it in a prospective controlled clinical trial.
Sir, in your trial, what was the dose?
Yeah, so we use 1.8 gray, we don't use 60 in 30, we use 59.4 in 33 fractions. We are actually doing a very conservative boosting. We are doing 5.4 gray boost in 3 fractions as a sequential based on the FET-PET avidity post 50 gray. So we acquire the FET-PET at 25 fractions, and based on the residual avidity, only that area is targeted. We don't target the entire cavity, we don't target the entire MR signal abnormality. So the selective boosting is only to the FET-PET avid region after 50 gray, and that too modest dose, 5.4 gray in 3 fractions, and only in unmethylated GBM where chemotherapy really doesn't work.
Sir. Thank you, sir.
Sir, I have a question regarding rigid and deformable registration. We know that in deformable registration, the images are made changes so that it fuse with exact anatomy, and we can actually use both the images. But in rigid registration, the anatomy is not exactly superimposed. In the last IPRO session which I attended in Chandigarh, so there the consensus was made that deformable registration should not be used, exactly cannot delineate the area where the GTB was initially present. But in many cases where there are anatomic variation, deformable is necessary to do sometimes, but we have to match it with the exact MRI what is the opinion that we should go for it or not?
I don't think anybody can make a very strong statement that it should not be used. I disagree with that. I think there are, it is contextual. Most of us don't have access to deformable registration. I mean, how many of in the audience have access to deformable registration? Oh, quite a few actually. I thought less than 10% would have access to deformable registration. We don't routinely use deformable registration, but I think in the CNS, I would be more sort of keen to use the deformable registration. I think the statement that it should not be used, I would not sort of endorse that statement. I don't think any group or any teaching course can make that kind of a statement that it should not be used. It is until such time that you understand what the limitations of that particular registration are, it's fine to use. Nothing is 100%, the deformable registration has its own set of advantages, it will have its own set of disadvantages. If you understand the pros and cons and use it, it is fine.
Sir, excellent one. Do you use any flare sequence for the city planning feature?
I didn't get your question.
MR flare sequence with the city planning. Once you fuse with the...
I'm sorry, you're asking, do you use flare
sequence for the city, once you fuse with the city planning process for the CNS tumors?
Yes,
especially.
of course. A lot of the IDH mutant diffuse gliomas that are primarily non-enhancing, it's the T2 propeller and the flare sequence that is required. Contrast imaging is useless for delineation. So we actually use all the three sequences and a lot of 3D volumetric cube flare sequence is used for the non-enhancing tumors, the IDH mutant diffuse gliomas. The delineation of the initial target volume is based on a cube flare sequence.
Mainly for the diffuse glioma or?
Yes, for diffuse. So that's why I'm saying if it is an IDH mutant diffuse glioma, which will be typically non-enhancing, you have to use either a T2 propeller or a flare sequence. You should not just go by the 3D, by the contrast imaging. T1 contrast imaging will give you very small volume. That's not. Most of the IDH mutant diffuse gliomas will have infiltrative non-enhancing component. Of course, flare you will include the edema as well. I mean, it's almost impossible to differentiate between infiltrative tumor and edema in IDH mutant diffuse gliomas. So all of that flare signal abnormality is targeted or drawn as the initial CTV or GTV, whatever you can call it, and then we give a 1 centimeter margin to it for microscopic disease and a setup margin of 3 millimeters.
When do you use contrast enhanced T1 weighted image? T1 weighted contrast enhanced image.
For glioblastoma, that's the recommended imaging for glioblastoma. For benign tumors such as pituitary, meningiomas, all of them you will use the T1 contrast for
so do you use especially for the boost or something that from the initial beginning itself?
No, we don't use MR for boost planning. As I said, we are doing it in the context of a randomized trial where we are using FET-PET for selective subvolume boosting.
Okay, thank you.
Thank you, Dr. Gupta, for that thought-provoking session. Now we move on to a topic that addresses the precision and accuracy needed in radiation oncology, errors and margin in clinical practice. Dr. Santan Chakrabarti will be sharing his extensive knowledge. Please welcome Dr. Chakrabarti to the stage.
Dr. Chakrabarti is a senior consultant in the Department of Radiation Oncology at Tata Medical Center, Kolkata. He is a silver medalist in MD radiotherapy.
Thank you for the kind introduction. While my presentation is opening up, Very good morning to all of you. And to start off, I would just like to know how many of you are 5 to 10 years into your practice? Can I have a show of hands? And how many of you are less than 5 years into your practice? Excellent, thank you. So I have been asked to speak about errors and margins in your clinical practice. Unfortunately, since I'm not really aware of your clinical practice, so I have to wing it as I go along. These are the learning objectives which I thought would be useful for us to understand the concept of systematic and random errors, to understand the nature and sources of these errors, and to understand how these errors are ultimately incorporated into margins that you use. Some of the key terms that you need to understand is what exactly is an error. An error is something that is not what you deliver, is not what you plan. That's what is an error. And a variation is what? Whenever there is a periodic or a recurringly occurring error. You can call this a variation. Uncertainty is a statistical term which quantifies how much of this variation or error will be there. And there is a very key word which we will be focusing on significantly during the presentation, that is geometric error. And what is this? This basically refers to the discrepancy between intended and actual treatment positions. Now, in radiotherapy, errors can be of various types, and geometric error is just one type of error. Not all types of errors are geometric errors. For example, if you are seeing a patient with a breast cancer which is ER positive breast cancer, for example, where you do not want to give the boost and you end up giving the boost, it technically becomes a geometric error because you have localized it incorrectly. But this is not an error which can be corrected by any kind of margin recipe. A short refresher of the ICRU volume concepts. I think most of you would be aware of this. Gross tumor volume is nothing but what you can see or what you can feel and what you can delineate on an image, the gross disease. The clinical target volume is a margin that is given on top of this gross disease to account for subclinical disease. And the planning target volume is a margin that is given to encompass two different types of uncertainties. One is an internal target volume, which accounts for motion and deformation. And the second is a setup margin, which accounts for uncertainties in daily positioning. If we classify errors, we can classify errors into two broad categories, systematic and random. Now, what are systematic errors? Systematic errors are errors which will remain during the course of the entire radiotherapy course. So, once that error has crept into your planning process, it will be there through the entire course of treatment, it will not change. A random error, on the other hand, is something that is introduced by a process on a day-to-day basis. So, in the course of a fractionated radiotherapy, the random error component changes. Now, what is the biggest problem for us is that it is nearly impossible to isolate these two error components separately on an individual basis every day. So, what we have to do is that we have to essentially rely on statistical techniques to get an understanding of the estimate of systematic and random errors. Now, systematic errors are mostly introduced by localization and planning. One of the examples that I gave you just now is an example of a systematic error. And random errors, on the other hand, will be basically a function of how good your setup is and how well trained your staff is, how good they are following the protocols. Typically, an individual systematic error is measured by averaging the errors, which means whatever the errors have happened over the course of the treatment for a single individual, if you obtain the average of these errors, you get a measure of this person's systematic error. For getting a population systematic error, what you need to do is that you need to get a standard deviation of the means. So, if you have 20 individuals, each of them will have a mean error. If you take the standard deviation of that mean error, you get a measure of the sample systematic error. In your case, it may or may not be the population. For random error, what you do is that you basically need to measure the spread of the error. So, how much is the distance or how much is the variation from the average? That is what is a random error. And typically this is calculated for an individual using the standard deviation. For population, what we do rely on is the root mean square of the individual error. Now, what is the consequence of these two errors? It is quite different. As you can understand, the systematic error leads to a gross miss. For example, here the same tumor has been treated and these portions of the tumor have been missed, and this will continue to happen throughout the entire course of treatment. On the other hand, in case of random error, what happens is that the dose distribution will sort of blur out. So, periphery of the target will get lesser dose than what you intend to, but will not receive a zero dose. So, this is very important. Now, mind you, these consequences actually increase more conformal you become. So, what happens is the greater the degree of your conformity. So, for example, in this case, my field edges are not really conforming with the shape of the tumor. So, you can see even if there is an error, there is still a little bit of dosage that goes on simply because I am not conformal enough. More your conformity, the greater the consequences these errors have. One very important concept to understand, and this is something that will be useful to you in the later clinical sessions also, is that whenever we deal with individual independent errors, these are added always in quadrature. What do you mean by errors addition in quadrature? Essentially, you take the square of the error, add it to the square of the next error, and take a square root to get this. Now, the mathematical principles underlying this is little complex, so I will try to make you understand using this. What I have done over here is I have simulated two different types of errors. Now, you can consider them to be any errors. For our purposes, let's say this is internal margin and the green one is the setup error. The internal margin distribution has an average of 3 and a standard deviation of 0.5. The setup error, internal margin has a mean of 6 and a standard deviation of 0.7. Now, what happens is for each day, suppose you simply add up the two errors, right? The setup margin and the internal margin. What you get is a distribution which looks like this purple distribution. If you simply add the errors linearly, what do I mean? Suppose you want to get the error that comes here, what you have to do is essentially take the average value over here, which is 3, plus average value of over here 6. What is that? 9. And suppose I want to take the standard deviation, 0.5 plus 0.7 will become how much? 1.2. So, this is the typical graph that will come if I simply add this linearly. This is what linear addition means. It means I am adding the standard deviations together in a linear manner. This is the graph that will come. Now, please remember, this is not the shape that comes from this distribution. The shape of this distribution actually comes from when you add these standard deviations in quadrature. So, that is why it is said, whenever you have independent errors, please keep in mind independent errors, you add them in quadrature. There is also an important property that these error distributions have to be normal, but that's something that we consider it to be a given. How do you calculate the systematic error? As we have already outlined, you basically for an individual, you simply calculate the average of the errors. And overall mean error for the population typically will be the average of these individual mean errors, right? So, average of average. Now, what happens is if you have this done in a reasonably good department, this error, that is the population error, should be somewhere near to 0. Otherwise, it indicates there is a significant process fault somewhere in your process. The population systematic error is obtained by the standard deviation of these individual mean errors, and this is the formula. For random error, what we need to do is we need to calculate the standard deviation of the measurements. So, these standard deviations for an individual person. So, suppose you have 10 observations for an individual person, you will have an average value and you will have a standard deviation for that individual. That standard deviation is a representation of how much variance is there from the average. In other words, it is a representation of the random error. So, what we need to do for each individual is we need to calculate the standard deviation. And from this, we will be therefore getting this formula, which is basically the standard deviation minus the average to the square. In this way, we keep on adding, divide by the n. Now it is important in this formula, what is happening is this mean value is being subtracted. Can you see this? Mu is being subtracted every time. So this calculation of the standard deviation actually takes out the population mean. For getting the population's random error, we need to calculate the root mean square of the standard deviation. So please remember, this formula and this formula are slightly different. So in this formula, what we are doing is that we are subtracting the average. Here we are not. We are just taking the standard deviation, squaring them and dividing by n. Now what happens because of the nature of this formula, this is heavily influenced by outliers. So what happens if you have a very small sample size for calculating your random errors? What will happen is, suppose there is a one outlier person who has a very significant change in the positioning, or another outlier where there is hardly any change in positioning, they will affect this formula very significantly. So this component changes a lot. So based on these, I think most of us are aware of these two formulas, Van Hoek's formula and Stroom's formula. So Van Hoek's formula specifies that you multiply the systematic error or the standard deviation of the systematic error by 2.5, add 0.7 to the random error term, and that is the margin for your CTV to PTV. Stroom's method, on the other hand, specifies that you multiply systematic error by 2 and add 0.7 to the random component. Now why is this difference? The difference is because of the way they have calculated this. So what you have to understand, one very important thing is, when they are actually doing these calculations, what are they trying to do? They were trying to find out a method of giving a margin which will allow you to treat a large proportion of your patients safely. And when you mean safely, what does that mean? It means that you are able to deliver a tumoricidal dose. So that is why they came up with this component. So typically for your standard ICRU prescription, we say that the lower bound of my dose coverage to the target volume should be less 95%. That's what we say. So that is how they said, for Van Hoek, they say that if you use this formula, what will happen? That 90% of the patients will receive a minimum cumulative dose of 95% of the prescribed dose. On the other hand, Stroom's method says, on an average, 99% of the target volume will receive 95% or more of the prescription dose. So you see that critical difference. Van Hoek is dealing with patients, Stroom is dealing with target volume. So there is a critical difference there. Now what are the biological consequences of different margins? Now why is this important is because whenever you are treating cancers, what happens is, depending on the margins that you give, you either end up irradiating a lot of extra tissue, or you end up exposing a less amount of tumor to the dose. That's what happens. So what happens is, whenever you have errors in conformal radiotherapy, tumor control probability will always reduce. It goes without saying. Why? Because there is never going to be a scenario where the error is going to increase the irradiation of the tumor. It will also worsen the normal tissue complication probability, because again, the function of conformity ensures that your tumor and your organ at risk sparing that you get will always worsen if you have an error. So margins will improve the TCP, and NTCP reduction, however, will only happen in areas with high dose gradient. That goes without saying. Suppose you have an organ which is located very far away where the dose gradient is not very sharp. Minor errors will not change a huge difference in the organ complications. Now one very important thing is that none of these margin recipes actually consider the fact that tumor clonogen density inside the tumor is not the same. They all assume that every single pixel that is occupied by the clinical target volume, missing them gives the same consequence, which may or may not be true. What about organs at risk? For organs at risk, in contrast to the tumor, we handle them a little differently when it comes to margin prescriptions. Now, it is important to understand the concept of organ at risk, and this is something that I have written, you can read it. What is important is that not every organ which is being irradiated is an organ at risk. So organ at risk is defined by the fact that it will receive a dose which exceeds its tolerance. One of the important concepts whenever you are considering margins for organs at risk is what type of organ at risk it is. Whether this is a serial organ at risk, which means losing a single functional subunit will result in catastrophic loss of function, or a parallel organ at risk where losing a proportion of the functional subunits will result in loss of function. The key difference that comes when you are deriving these margins for organ at risk is that in case of an OAR, we are interested only a single dimension. Why? Typically, your OARs are adjacent to the target volume. So only when the error happens such that the dose shifts onto the OAR will there be a consequence. The other side, the dose will always reduce. So that is not going to be a consequence for you. So that is why you will see, if you see McKinsey's paper, they have given the margins for OAR. The multiplication term for systematic error is not 2.5 but 1.3. So that is where it comes from. Now, all of us, I think, are now using image-guided radiotherapy. Is there somebody in this audience who is not using image-guided radiotherapy? Can you please raise your hand? No one. So that was something. Now, in the earlier era of radiotherapy where image guidance was not performed systematically, which means a significant proportion of the fractions delivered were non-image guided, the vast majority of the errors used to be determined by the accuracy or the veracity of your setup. Nowadays, what happens is with advances in image guidance, setup errors actually take a backseat, because with daily image guidance, what you end up doing is correcting those setup errors every day. So although your setup errors are there, they are not gone away, but the magnitude of those setup errors reduces. So what happens is the other error components actually become more important. And what are the other sources of errors that can come? You can have errors because arising out of deformation of the targets, fusion, as we have said, delineation, the most important component of the error. You can have errors arising from rotation of the patient, intra and interfraction errors, surrogate errors, matching errors, and technical delivery errors. So all of these types of errors actually will keep on adding, and it is important to understand that all of these end up leading to your systematic and random error component. Now, the most important error which Dr. Tejpal highlighted in his lecture is delineation error. So what is this? Basically a discrepancy between your target contour and the true contour. Now, why is this such an important problem is because we unfortunately are relying on imaging which may or may not be perfect, and this delineation is done by humans who may have a completely different level of skill and knowledge, which is why these kind of discrepancies occur. And these are the various factors which are known to be associated with delineation accuracy. I will not belabor the point, but all of us, I think, has everybody drawn volumes on CT scan here, especially the doctors? Is there any doctor over here who has not drawn volumes on the CT scan? Right, so everyone has. So you will understand that your dedication to the task is vastly more when you are doing it at 9 a.m. versus when you are doing it at 5 p.m. in the evening. That goes without saying. It is also affected by the number of phone calls which you receive when you are doing the delineation. So all of these factors, these are like very difficult factors to control, but all of these affect how accurate your delineation is. Now, the question that comes is, how do you measure this error? Right? Now, how many of you are working in setup where you are the only person who are doing the delineation? No one. So all of you are working in setups where there is somebody else who looks at the contour after you have drawn the contour. So somebody verifies what you have drawn. Is that correct? Okay. So if that is the case, then things become a little easier. So what happens is, when you are measuring delineation errors, this is very important, please mind it. You have seen there are several metrics which have been used, or which Dr. Tejpal had shown to, determine how good your automatic segmentation algorithms are. They are not actually useful for determining error. This is very important. So metrics like dice coefficient, Jaccard coefficient, Hausdorff indices are not useful for determining the error magnitude, although they can tell you how much error is there. In order to actually measure delineation error, what you have to do is that you have to actually set up a proper study. How you do that? You basically ask people, whoever are doing the delineation in your department, to actually do the work on representative cases, which means you have 3 or 4 representative cases where you actually ask them to delineate. Now, how this becomes problematic is if suppose you have a group where the vast majority of the people who are doing the delineation are trainees, and there is only 1 or 2 single senior person who has sufficient expertise to actually check the contour. That is where the problem lies. Now, if you are doing these studies are not supposed to be done in that manner. They are supposed to be the delineation errors of the experts, not delineation errors of the trainees. This is important. So this is an example picture where the prostate gland has been delineated by several experts. And you can see there is a variability. So how they do it that? All these blue color contours are where the prostate has been delineated, and you can see the moment the prostate went off, or the lower penile bulb area, there is a significant discrepancy even between the experts. Now, these studies are not unique to prostate. These have been actually done for almost every site that you can imagine, and they all show wherever there is poor quality imaging or lack of appropriate guidelines, you will get variation. So how do you actually get the systematic and random error components out there? So what they recommend is that you basically measure the distance between the range of the contours, and then you use it to calculate the systematic and random errors for delineation. This is a simple example. So for example, if we go by to that, here the range is about 8 millimeters. So this is in the x-axis. So the standard deviation for this will be something that can be approximated using this range formula. And this, by the way, the reference I will be providing to you, so you can go through it. The range formula specifies that you divide the range by this term d to n, which basically depends on the sample size. Why we are not simply calculating the standard deviation is because if you have a small population sample size, then this is reasonable approximate of the standard deviation. If you have like 50, 70 observers who have done the delineation, then you can simply calculate the standard deviation. So you just plug in 8 and figure out, suppose 10 people have done it, divided by 3.08, you will get the standard deviation. One very important point which helps to reduce the error is peer review. Now, these things what we have shown, that is delineation errors, exist. And everybody knows that if you delineate the same case after 2 hours, you will get a different contour. So what happens is, one of the things that is important and recommended is whenever you are delivering radiotherapy to complex tumors, complex sites, it is important to set up a proper peer review system, because that's one of the most important mitigation measures against unwanted errors. And this is our experience which we did in Tata Medical Center for Gynecological Cancer Patients. What I want to highlight to you from this experience was that even after peer review, it never sort of happened that our errors became 0. A significant proportion of patients continued to have errors which were identified during the peer review process. So, peer review is not going to be a one-shot done affair. It has to be a continuous process in your RTTQA process. What about automatic segmentation? I would like to know how many of you are using automatic segmentation regularly in clinic? Anybody? Right. So quite a few of you are already using automatic segmentation. Now, one of the important things is that automatic segmentation software, of course, has to be commissioned. Please consider the fact that just like you commission TPS, the software also needs commissioning. And if you are developing your own model, then what you should be doing is that the commissioning process should be very detailed. It should have description of the data set that you have used for the training. You should report the quantitative metrics as was highlighted by Dr. Tejpal, as well as the qualitative metrics. So typically experts would delineate and you will rate the contours which has been done by the automatic segmentation. So for automatic segmentation also you can calculate the errors. But if you ask me, this point of calculating errors for automatic segmentation is a little moot, because till now I don't believe anybody allows the automatic segmentation to simply go on to the planning stage. I don't know anybody allows it, or everybody, there is a human in the loop which actually reviews it. So I think no one has actually gone to the stage where we allow the automatic segmentation to directly go to the planner. So that part or this margin calculation probably is not something that is currently very important. How many of you are using image registration in your radiotherapy workforce? Yes, again, a significant majority. So whenever you are using image registration, how many of you have written down protocols for image registration? Right, smaller proportion than before. And who does your image registration? Is it the doctors or the physicists? Plus minus. Okay. So, you know, image registration is also an important source of error, particularly if you are relying in it to delineate your target volume. And this is, of course, a given, for example, in sites like brain tumors. In other sites, you know, for example, gynecological cancers that I treat, for example, image fusion is used as an assistance, but not really something that we delineate the target volume on. So the impact of that error is lesser, but nonetheless, if you are using fusion, then it is possible to quantify the fusion errors also. The process is quite similar. You simply do fusions on representative contours, repeated fusions, and find out the errors in those fusions. What about deformation? Whenever you have organs which are in the abdomen, pelvis, thorax, or soft tissues, they will move, they will change its shape. And deformation error is another important consideration whenever you are considering your CTV to PTV margins. Now, practically speaking, what we do is that we use an ITV based approach. That is what is commonly used, because these deformation errors are often difficult to consider with a simple margin, but theoretically it is possible to calculate margins for deformable errors also. How many of you are using ITV based approaches for your planning? Right. So I think today we have a clinical session where we will be having discussion on the gynecological cancers, and we will have a discussion on that also. Another alternative approach is, of course, adaptive radiotherapy, where you have a sort of set of plans which are for different sets of image shapes or target volume shapes. On the day you see what shape or position the target volume is in, you choose the treatment to be delivered based on that. These are how you calculate the standard deviation and the random errors for deformation errors if you are interested in doing that. What about rotational errors? Now, how many of you have access to a 6-DOF couch? Right, a quite significant large number of having access to 6-DOF couches. So what happens is, whenever you have access to 6-DOF couch, in addition to translational errors, you start getting rotational error information also, like pitch, roll, and yaw. Now, it is important to understand that these rotational errors also contribute to your errors, and as a result, they can also be considered in your margin calculation. So one of the ways which has been recommended is to determine the translational component that arises from the rotation. So take a look at this graphic to understand what is happening. The red is the original picture or the original tumor, and there is a yaw which has moved this by an angle theta. So how you can calculate? You basically calculate the displacement of this point, that is the extreme point, by this value x, and this is a simple trigonometric relationship. So x will be equal to y into sine theta. So based on that, you can calculate the displacement and convert a rotational error into a translational component. So this is how you convert. So pitch errors will require your translation in the y and the z axis. Roll errors will require correction in the x and z axis, and yaw errors will require translational correction in the x and y axis. The guidance also mentions a shape factor, which basically is a factor that is used for different shapes of the target volume, and it is required if your shape is very oblique or irregular shape. So rotational errors, as I mentioned, can be decomposed into these two components, and we can use it to calculate the systematic error. Oh, my time is up? Okay, okay. So quickly, what are surrogate errors? Surrogate errors are arising when you have a surrogate for matching, and examples are clips fiducials, but also, for example, if you have two target volumes which are irradiating. For example, you are treating the pelvis where you're matching the gynecological pelvic volume, and you are primarily focusing on matching that, the nodal volume is not being matched as well. So then the pelvic volume becomes a surrogate for that. Matching errors and technical delivery errors are also very important. As I've already mentioned, you will add these error margins in quadrature. How do you derive the CTV PTV margins? You simply multiply the systematic error and the random error components, and this will give you the error margins. My presentation will be available online and the URL will be shared, so I will not spend any more time on this. Thank you.
Thank you, Shankar. I think if nobody has any burning questions, in the interest of time, we'll move over to the inauguration and we'll take questions for Shankar in the discussion session at the end of the morning.
Thank you, Dr. Chakrabarti, for shedding the light on such an important aspect of clinical practice. Now, we will hand over to Dr. Meenakshi Misra and Dr. Shanmugha Priya for the inaugural session. Over to you, ma'am.
Thank you, Beena. Good morning to all.